It's my great privilege and honor to introduce Dr. Milani. Dr. Milani is visiting from Italy and is joining us virtually today and is going to be talking to us today about advancements in AL amyloidosis care. So Dr. Milani, thank you very much for being with us today. We're very grateful for your time and we're very much looking forward to your presentation.
Thank you. Thank you so much. I'd like really thank the organizer for the invitation. I'm really sorry that I can't join you in person. My plan was to come to Canada, but unfortunately, a couple of days ago, I have a horrible flu, and I was really unable to face a long trip from Italy. So I'm really, really sorry for that. Please go to the next slide. So and the next again. So we are now. I would like to thank also Victor particularly for the invitation to this really exciting meeting. And again, sorry. So moving on my topic, we know that AL amyloidosis is one of the most important amyloidosis. We hear the advancement in ATTR and AL is of course one of the most important, and in the last nomenclature committee paper is one of the 42 different protein that is able to create amyloid. Sorry, they texted me that. Do you see the slides or not? Just let me know, please. Okay. So next one, please. One of the major advancement in the last few years is that we also in our center, that is the Italian National Referral Center, we faced an exponential increase in the number of ATTR patients, in particularly ATTR wild type, and so we had the opportunity. We also notice an increase in the number of patients with AL amyloidosis. And also, as we know for ATTR, in which there is an increase in terms of the overall survival in patients with TTR, as reported by the London group, another one of the major achievements, one of the major improvements in the last few years also for in AL amyloidosis patient is the expected improvement in survival also for AL amyloidosis patients. This is really important, and we saw that in our cohort, and also other centers already reported this important achievement, and probably this is going to be better in the year to come if we think the major advancement in treatments and the major advancement in the different possibilities that we will have in the future. So this is another important point. Please go to the next. Unfortunately, I tried to see in my database, in our AL prospectively maintained database of the PAVIA cohort, if we observed also an improvement in terms of the types of patients that are diagnosed. We probably in the room all are aware of that we can have different stages, and we will see in the upcoming slides something related to the staging and some update and some advancement also in the staging systems for AL amyloidosis. But if we use the Mayo staging system based on NT-proBNP and troponin for AL amyloidosis, we can see that in the last 5 years, we have an increase in the number of patients diagnosed in stage 2, as we can expect, because there is an increase in the number of diagnoses, an increase in the number of patients with cardiac amyloidosis that are seen thanks to the more aggressive approach from cardiologists, but unfortunately there is no decrease in the percentage of patients that are diagnosed in advanced stage. This is not present in the ATTR field, in which the London research reported that there is an improvement in the numbers of diagnosed patients, but also these translate also in a higher chance to be diagnosed in stage 1, so with an early stage of the disease. Unfortunately, what we saw in our prospective database, so in a real-world setting, there is no an increase in terms of, there is no a significant decrease in the patients that are diagnosed in the late stage of the disease, in an advanced stage of the disease. And this is, please go to the next, this is despite the fact that we have now different algorithms. We will probably discuss the diagnostic algorithm in the upcoming session, in the diagnosis session, but this is one of the algorithms. This is one of the last algorithm, and I can say this is one of the algorithms that I like the most, because it puts in the center, in the first part, the most important point related to the diagnosis, so the identification of the monoclonal protein in patients with a suspect cardiac amyloidosis. Because this is the fact, this is the point that turn to the non-biopsy diagnostic approach, or to the necessity to the of the biopsy-proven approach for the diagnosis. So please go to the next. And we described next again. So we described recently that patients that perform with cardiac amyloidosis only, with AL cardiac amyloidosis only, so only cardiac involvement due to AL amyloidosis, that received a diagnosis and had the possibility to be tested for the presence of monoclonal protein in an earlier phase of their diagnostic process, so less than 6 weeks after the first medical contact, after the first suspicion of the disease, they can reach the diagnosis in an earlier phase of the disease. And those who were tested for monoclonal protein studies after 6 weeks, or after more than 2 months approximately, they received the diagnosis later, and unfortunately they have less chance to survive, because obviously they can be more frequently in advanced stage of the disease and have a survival disadvantage. So this emphasizes the importance of having a correct pathway for the diagnosis. This highlights the importance of the knowledge regarding the disease. The knowledge regarding ATTR is well established amongst cardiologists and also amongst other physicians. But unfortunately, the knowledge that the most important and the first and most important point is to exclude AL amyloidosis in all patients needs to be emphasized, because in these patients, a few weeks can change the outcome, can change the possibility to have an earlier diagnosis. Please go to the next. So our approach in Pavia, but again, I will talk about our approach in the upcoming session, is obviously a diagnostic approach based on biopsy. For AL amyloidosis, despite the advancements in images, for example, the new amyloid tracers that can be used for amyloid, but for the sake of time, I will not cover I will not cover this point, that will be discussed later. We need a biopsy-proven approach for AL amyloidosis. Next, please. And we need to identify the amyloid deposits, and obviously we need to type the amyloid deposits with immunohistochemistry, with immunoelectron microscopy, or proteomics. Please go to the next. So our approach is for all patients with signs and symptoms of amyloidosis, please next, is to identify, search for the presence of monoclonal protein or not. Next, please. If there is no monoclonal protein, a non-biopsy proven approach can be performed. Next, please. If there is a monoclonal protein, tissue biopsy is required, and typing is also required. Next, please. Obviously, if a patient has a monoclonal gammopathy of undetermined significance in follow-up, this is mandatory immediately. The importance of having in this subset of patients immediately a biopsy-proven approach to confirm or to exclude the presence of AL amyloidosis, or to confirm or to exclude the presence of another type of amyloidosis is important. Next, please. Because only when we reach the biopsy-proven diagnosis, we may consider to stage the disease and to refer the patient for treatment. Next, please. Our approach, next please again, our approach in Pavia is to promote a screening program for patients with monoclonal gammopathy of undetermined significance. Thanks to the seminal idea of Professor Merlini, my mentor in Pavia, that proposed 10 years ago to introduce the use of NT-proBNP and albuminuria evaluation in all patients with monoclonal gammopathy of undetermined significance with high risk MGAS, so with an abnormal free light chain kappa-lambda ratio. We introduced this screening once a year in all patient follow at our hematology department. In Pavia, the hematology department is separated from the amyloid unit and is following hundreds of patients with MGAS. And amongst those patients, we found 60 patients with abnormal biomarkers during the course of the follow-up. In these 60 patients, 22 were found to have an asymptomatic AL amyloidosis, so only the presence of abnormal biomarkers without any signs and any symptoms of the disease, but an asymptomatic disease. All these patients were diagnosed based on biopsy-proven approach, and all of them received treatment. And in all cases, we obtain the possibility to give them all types of treatment, and in all the cases, we obtain a good hematologic response. In the remaining 40 patients that had no diagnosis of AL amyloidosis, another diagnosis was reached, so with renal biopsy or cardiac amyloidosis were excluded by cardiac magnetic resonance. So the introduction of a screening program based on biomarkers, NT-proBNP and albuminuria is another advancement, is another major advancement, I can say, because we will probably be able to find in the subset of patients with MGAS, at least in the subset of patients with high-risk MGAS, a major number of patients with asymptomatic disease. Next, please. Is fundamental to find asymptomatic patient because they can be in stage 1, so patients with low NT-proBNP and low troponin, so with a really good outcome. Because our goal has to be to don't find patients in stage 3, so with very advanced cardiac disease, defined by an NT-proBNP more than 8500 and a troponin, elevated troponin. Next, please. The Boston researcher taught us to use also BNP instead of NT-proBNP, so we probably can screen also using BNP. And we know, next please, that the difference between involved and uninvolved free light chain has also a prognostic role, because those with elevated DFLC have a dismal outcome. Next, please. Next, please, again. But the London researcher more recently reported that amongst patients in stage 4, based on the so-called Mayo staging system, can be stratified according to NT-proBNP concentration. So in this subset of patients, there is a subset of patients with a really bad outcome if we consider patients with extremely elevated NT-proBNP. Those patients remains an unmet need for treatment, and obviously those patients, we don't want to see this kind of patient at the time of diagnosis. Next, please. Another major achievement, a major advancement recently is to better understand the role of cytogenetics. We know that AL amyloidosis is different compared to multiple myeloma. We know from previous studies that almost 50% of our AL patients have the translocation 1114 as the major cytogenetic abnormalities. And this was associated with a poor response to treatments based on bortezomib, but not based on DARA CyBorD, for example, that may overcome the resistance of the use of the presence of this translocation. Unfortunately, recent data from my friend Dr. Cercabotti from the Memorial Sloan Kettering that gathered data from all over the world show that the presence of GAIN1Q21 can be a negative prognostic marker also in patients treated with a daratumumab-based regimen. So 20% of our patients that harbor these cytogenetic abnormalities may be at higher risk compared to others. Next, please. We know that AL amyloidosis patients are different compared to myeloma, but we know that amongst patients with AL amyloidosis, also the phenotypic characteristics of the plasma cells of the bone marrow can be evaluated. And thanks to this important paper from the Spanish group, in collaboration also with our center, we confirm that also in AL amyloidosis patient, we may identify a subset of patients with a multiple myeloma-like plasma cells and those with a more MGUS-like phenotype that have a different outcome. Despite all these advancements, next please, in the evaluation of the disease, I think that the major advancement of the recent years is the fact that now we have the guidelines for treatment for AL amyloidosis. I believe that this is an advancement because I started working on AL amyloidosis 14 years ago, and at that time we have few therapies, obviously, but also we had no guidelines. And the discussion with patients, but sometimes also discussion with other clinicians, is what is the best option? What is the guideline? What is the first line option for AL amyloidosis? At that time was not clear. And every center have their own, for example, have their own different eligibility criteria for autologous stem cell transplant. Next, please. Now, thanks to these guidelines, the International Society of Amyloidosis and the European Hematology Association define a specific eligibility criteria checklist for transplant, and here are reported. So the presence of a non-advanced cardiac involvement, the presence of good performance status, and all other aspects. Next, please. Our approach, following the guidelines now, is to use an induction regimen based on daratumumab, cyclophosphamide, bortezomib, and dexamethasone in all those transplant eligible, and evaluate response immediately after 2-4 cycles, and then decide if a patient already reached a complete response. We may also consider to observe the patient and defer the autologous stem cell transplant. For those who did not reach a profound hematologic response, we can suggest to perform transplant only if the patient is eligible, obviously, and if we can consider to use high-dose melphalan. In all patients who did not reach response, a relapse refractory algorithm is required, and all the others, no maintenance is required. Next, please. For those who are not eligible to autologous stem cell transplant, neuropathy is a major issue because the first-line option is daratumumab, cyclophosphamide, bortezomib, and dexamethasone in all patients cardiac stage 1 to cardiac stage 3A. So for the majority of patients without neuropathy. For those with neuropathy, we have to avoid the use of bortezomib, and so the best option that is proposed by the guidelines is the use of DARA single agent or other options. The unmet need is still those patients with cardiac stage 3B, so the really advanced patient, because in many countries, the Dara-CyBorD is not available in this subset. For example, in Italy, is not available. And so we need to use reduced dose of cyclophosphamide, bortezomib, and dexamethasone, or bortezomib, melphalan, and dexamethasone. Next, please. The use of Dara-CyBorD is based on Andromeda. Probably all of you already knows the impressive results of Andromeda, and we awaited the updated results, the further results that will probably come in the future with the analysis on overall survival. Because now we have hematologic response data that are impressive, 90% of patients with an hematologic response, with a high rate of complete responses in those patients who receive Dara-CyBorD. Next, please. Daratumumab can be, next please again, it can be used in stage 3B, and many retrospective series already reported the role of this drug and the safety of this drug, single agent or in combination in this subset. And a single agent, the major achievement are the results of the EMN22 study led by Professor Castritis and presented last year at the EHA, with an impressive overall survival, median overall survival of 10 months in this subset of patients that we know have a really poor outcome at diagnosis. So probably daratumumab single agent may be considered as the best option for this subset of patients. Next, please. Other combination for relapse refractory patient can be daratumumab, again in combination with pomalidomide, as we studied in our phase 2 study, or isatuximab, pomalidomide, dexamethasone, as the French group reported at the last International Society of Amyloidosis Symposium. Both those approaches have to be considered for all patients who did not receive daratumumab, and unfortunately, probably not for the upcoming years in all the patients that receive daratumumab first line. Next, please. The approach for relapse refractory patient is based obviously of what the patient received first line, and actually is now still based on the use of immunomodulatory agents. Lenalidomide and dexamethasone is the only available second line option in Italy, for example. Pomalidomide and dexamethasone is accessible only as third-line option, and venetoclax is not accessible in Italy. This is another important unmet need for our patients, at least in my country, because, next please, we know that venetoclax is a really impressive drug, and many retrospective series already reported a high chance of overall response rate in a relapse refractory setting, with 50% almost patients that reach complete response in this setting. So a real unmet need is the fact that this drug is still not available in many countries, and the fact that unfortunately we did not have clinical trials with the use of this drug in AL amyloidosis. Next, please. Best second-line option were studied by the Mayo Group and reported the possibility to use BCL2 inhibitors or autologous stem cell transplant or other option in those patients exposed to daratumumab. But obviously, we need to test in larger series what is the best second line option. Next, please. A possible option could be belantamab mafodotin. We know that this drug was stopped in the development for multiple myeloma a couple of years ago, but now, thanks to the results of the studies presented at ASCO last year, probably will come back in the market probably soon. In AL amyloidosis, this important phase 2 study reported good hematologic response rate, and next please, with the rate of adverse event that is manageable and comparable to those who were faced in multiple myeloma patient. So probably in the future we will have this option, and this could be another advancement for AL amyloidosis patients. Next, please. Other treatment options are the use of teclistamab that was reported by the French group that coordinated analysis of many centers that used teclistamab, and again the group of Memorial Sloan Kettering reported a series of few patients treated with teclistamab. So this is another treatment option that we will probably have this option in the future too. Next one. CAR T-cell is another chapter, is another potential a major advancement also for AL amyloidosis. The group from Israel reported at ESA the updated analysis of their cohort of academic CAR T-cell with good hematologic response data and good safety data regarding the use of this approach. So we will probably see in the future also new data, hopefully, regarding this approach. Lastly, another important advancement, but next please, will probably come when the results of those clinical trials will be available. We know that the KL101 is an antifibrillar antibody still under investigation in 2 different clinical trials, both closed for enrollment, and we eagerly awaited the results of these clinical trials in order to see if this drug will definitely change the outcome of our patients, and so if this drug will be available in the future. Also, birtamimab is another important compound that is still under investigation. The difference is that this trial is still ongoing, so we will probably need few more time to have results, but we will eagerly awaited the results of this study, because we know from the previous VITAL study that specifically in the subset of patients in stage 4, the use of birtamimab was associated with a better outcome in our patients. So moving to my last slide, please. we really have a major advancement for AL amyloidosis care, because now the major advancement in the recent year is the presence of a first line available for almost all patients, that is daratumumab, cyclophosphamide, bortezomib, and dexamethasone. But probably this is not enough, because unfortunately this is not a treatment regimen available for all patients, because unfortunately we still have patients that cannot be treated with this drug. And so we need to work better on diagnosis. We need to work better in order to find a non-advanced patient that can be treated with this regimen. And so working on diagnosis is important. Working in collaboration with other physicians is fundamental, and using also other techniques or screening program in order to identify earlier patients. Major advancement will come from the results of the ongoing clinical trials regarding antifibrillar antibodies. We hope to have these options soon in the market. With that, we go to the next slide. I'd like to thank again Dr. Zapeda, Victor from the invitation, and all the Canadian community. Really apologize me to not be there in person, but I will be online also for the next session. And I'd like to thank all of you for the attention.
Any questions?
Doesn't seem, okay, now it's on, thank you. Thank you, Dr. Milani. That was a fantastic presentation, and we're glad you're feeling better. We hope you continue to improve, and we're grateful that you were able to present to us today. So we're just seeing if there's any questions in the audience, or there's any virtual questions from the Zoom audience as well. While we're waiting for some more questions, I wonder if I could just ask you a couple as well. So my question is with regards to the monoclonal gammopathy of undetermined significance patients in the ATTR population. So this is often a source of trouble and confusion for cardiologists and neurologists alike who are caring for the ATTR patients. Of course, we screen for MGUS, and we're finding more and more of it all the time. I guess so. My question is twofold. You know, it sounds like you and your colleagues have set up quite an advanced system for these patients in Pavia, and congratulations to you. We similarly have an MGUS clinic led by our friend and colleague Dr. Zapeda in Calgary. So my question is number one, just if you could expand a little bit on the risk level and stratifying those MGUS patients, particularly in the ATTR population, where a lot of our organ-specific measures are confounded by having ATTR. So their NT-proBNP and troponin levels, they may have neuropathy from their ATTR. So stratifying their risk for progression, and then just the practical aspect of monitoring and following them, and just the sheer number of those patients as we diagnose more and more ATTR. Is that all done within your clinic and your cancer center? Is monitoring at times deferred or put on primary care or other care providers, given the growing size of this population? So risk stratification and then ongoing monitoring and the practicality of that.
Thanks for this really important question. So we know that in ATTR patients, we may have approximately 20 to 30% of patients with a monoclonal gammopathy of undetermined significance. So obviously the number of patients is really exponentially increased, as you mentioned. we need to stratify the risk of having moving from an MGUS to a multiple myeloma, because the risk in these patients, I believe, is the risk of progression to symptomatic multiple myeloma that can be dangerous and need to be evaluated every year. And what we have so far is the risk stratification of the International Myeloma Working Group criteria. So looking the measurement of relay chain, looking the type of MGUS. So if the MGUS is an IgG, is a low risk. If it is not an IgG, it can be considered as immediately as an intermediate risk. And obviously and so using these parameters, we may stratify the risk, and we decide if the patient has to be followed by an hematologist or if the patient can be evaluated once a year by a primary care physician. In Italy, we have two different approaches. All patients with with an intermediate high risk MGUS, so patients with a high free light chain and non-IgG monoclonal gammopathy, are followed by hematologists, and so the hematologist is doing the job. For those who have a low risk MGUS, primary care physician is asked to follow the patient. What I can say, in my clinic, we now have hundreds of patients on treatment, for example, with tafamidis for ATTR wild type, and we are forced to follow them every 6 months due to local regulation. And so actually in all patients with ATTR and MGUS, we are following also this every 6 months. So far, we had no patient that progressed to multiple myeloma, but obviously in the future, we may have this kind of situation.
Yeah, thanks very much for those insights. That's great. And I actually have a follow-up question to that. So the low-risk MGUS patients who can be followed by primary care, do you, in your experience, is the criteria for progression and monitoring kind of well understood by the primary care physicians who are following? And just in your experience, have you seen those progress on, and has that provided any insights into recommendations for ongoing monitoring to their primary care provider?
Yes, so the point is that in most of the cases, the primary care physician provide follow-up the first year, the second year, and in most of the cases stop to provide the follow-up subsequently. So what many hematology departments in Italy are providing to the primary care doctors is a kind of a spreadsheet with 3 or 4 blood tests that have to be performed once a year. So really in written, a kind of written instruction on how to follow the patient during the follow-up. So the point to me, I think that the awareness regarding MGUS particularly in patients with ATTR is probably higher because patients are now educated and patients are really more active in the evaluation of all the aspects. But of course, we need to provide also to primary care physician the importance of at least once a year follow-up, also in order to be sure to evaluate and to identify eventual AL patient earlier. So I think that the awareness in this is the most important point.
Oh, that's excellent. Thanks very much again. And I don't want to keep you all to myself. I'd like to see if there's other questions that we have. Can we just get a microphone? We're just going to get a microphone to someone you know very well. Dr. Venner has a question or comment for you.
Thank you very much for that excellent talk. I have a question about patients with myeloma and amyloid, where the frontline option could be, at least in Canada, of course we have the option of Dara-Cyborg or Dara-RD. And I'm wondering if you struggle with the same question, not so much about what is the best treatment to get the disease under control. I think Dara-Cyborg does very well in that initial setting. But when they have the underlying higher burden of clonal disease, do you think there's a role for the lenalidomide component long-term? So more of a DRD approach to maintain the disease control, because my personal opinion is that's the better option over the long run. But I'm wondering if you have any thoughts on that. We struggle with that one.
Thanks. Thanks really for this important question. So my feeling is the same. So for patients with I can say asymptomatic multiple myeloma and AL amyloidosis, we used to promote a more I can say aggressive, but it's not aggressive sometimes, but a more myeloma-like approach. So obviously for those patients, the use of a DARA-containing regimen is the best option, and promote an early assessment for autologous stem cell transplant is also still important, I think, in this patient, or obviously in those who are eligible. In those who are not eligible, my feeling is that probably DARA-RD can be a better approach also because, for example, for our regulation, Dara-Cyborg is a fixed time treatment. So for national authorities, Italian authorities, we must stop daratumumab after 24 months of therapy with Dara-Cyborg. With Dara-RD, we are not forced to stop daratumumab. So sometimes we discuss with the local hematologist to consider to use Dara-RD instead of Dara-Cyborg, because you can continue daratumumab up until progression and not just 24 months. Another issue that we may consider is the comorbidity of the patient. Obviously, the only caveat that I would like to emphasize is that I will not suggest the use of DARA-RD in a patient with renal AL amyloidosis due to the potential toxicity of lenalidomide. But this is not the only subset of patients which I will not suggest this kind of option.
Great, thanks very much for that detailed answer. I think we have a minute or two for more questions. A couple minutes. Any other questions from our audience here? Yeah. Well, I might ask you one more question then, Dr. Milani. So there's a lot of excitement and buzz, as we were just talking about, in transthyretin amyloidosis with regards to depleters, we're calling them in the ATTR space, the anti-amyloid monoclonal antibodies that have been tested and are being looked at further in AL amyloidosis. I wonder if you could make a prediction on the future about what their role might be and how successful they might be in AL patients, and do you think they'll become more standard? Do you think they'll become an important part of the treatment armamentarium? And if so, would they be something that would be used concurrently with chemotherapy, or would they be kind of more in the remission stage of the disease treatment? So if you have a crystal ball to predict the future, what do you think might happen?
This is the point. We need a crystal ball. At the end, we probably need a crystal ball to answer, because I think that we really need the answer will come from the ongoing clinical trials, because and I really think that from all the three clinical trials we will have the final decision, because I remember the day when all the studies related to the NeoD-001 were suddenly stopped, and also how this was a bad news for all the amyloid community, because we were excited at the time regarding the use of an anti-amyloid compound. We were all excited because the trial was running okay and everything was looking good. But suddenly stopped, and all the amyloid research felt like, okay, no way, we have to still on chemo. So probably now there is less excitement compared to almost 8 years ago. But we really have, I think and I believe that we have to be cautious, but we have to hope that these drugs will work, and obviously, probably all of them will work on top of chemotherapy. We will probably continue to need a chemotherapy approach, because we need to stop the production of the free light chain, and we know that this is translating in an improvement in the outcome. This will probably translate in an improvement in terms of overall survival. And this is translating already in an improvement in organ function, because from the important studies from Eli Mukhtar, from the Mayo, they described and defined the cardiac complete response patients, so patients who obtain a complete remission of the cardiac disease based on cardiac biomarkers. And all those patients had received only chemotherapy. So we know that thanks to chemotherapy, we may reach also cardiac complete response and also renal complete response. But if we can reach this goal earlier, thanks to the use of another drug, I really think that we will probably change the outcome of our patients. So really, with a crystal ball, I hope to see in the future the combination of maybe two antibodies, daratumumab and another antibody in a therapy, and in order to obtain earlier the cardiac complete response and the complete renal response in our patients.
Well, thanks very much for your insights, and sorry to put you on the spot like that to kind of predict the future, but grateful for your thoughts.
Yeah, I hope to be able to discuss in an upcoming Canadian summit if you
yes,
would like
to
invite me again.
Wouldn't that be that'd be exciting? Yeah, no, we've called on you heavily over the years, haven't we? And we've been grateful for all of your all of the education you've provided us. Okay, I think we can wrap up that session. So I want to thank Dr. Milani again for an excellent presentation.